Hello and good morning, everyone. So, welcome to another live session on Ident2. So, today we are mainly going to focus on general pathology. Okay. So, now less than like nearly 30 days remaining for your NEET MDS 2025 examination. And this will be the time that you will be revising or going through all the subjects once again. Okay. So, to help you in the process, Ident2 has come up with like a fast track revision series where we'll be discussing some of the important questions from some of the important topics from each subject. Okay. So today we are going to discuss some of the important questions from general pathology. So as you all know by now, general pathology together with microbiology, you can expect a total of like 14 questions. Okay, so from general pathology alone, you can expect somewhere around like 6 to 7 questions for your NEET MDS examinations. Now, what kind of questions can be asked in general pathology means there'll be definitely like image-based and clinical-oriented questions will be definitely there. And you can also expect like simple, direct one-liner questions also. Okay, so in today's session, we will first discuss about the uh, questions that had appeared in the recent NEET MDS 2024 examination. Okay, why we are discussing the questions that appeared in the recent NEET exam? Because then only you will get an idea about the pattern of questions or about the type of questions, how they can ask the questions in the NEET exam. You will get an overall idea about it. Okay, so first we will discuss those questions and then we will move on to some of the high yield questions from the general pathology subject. Okay. So if you look at the topics that are important in general pathology, now just few days remaining for your NEET exams, and you if you are like if you don't get time to go through all the topics, then I'll tell you some of the very important topics that you should definitely not miss in general pathology. Okay, so the first one is genetics. Okay, so if you look at the recent NEET MDS 2024 exam, there were like two questions asked from genetics alone. Okay, one was an image-based question and another one was like an clinical-oriented question. Two questions from genetics alone. We will discuss that in detail, but definitely genetics is an important topic. Then comes infections. Okay, among the infections, bacterial, viral, very important. And among the bacterial, viral also, like tuberculosis and HIV. Definitely one question from tuberculosis and one question from HIV can be expected. Okay, then next is the like the inflammation and all. Okay, mediators of inflammation. That is also an important topic. Now, following that, neoplasia. Okay, neoplasia, like we can't like particularly point out like these topics are important, but neoplasia and the all the mechanism of the cancer formation, tumor formation, the carcinogens, the how to detect the chemical carcinogens, and the characteristics of each tumor, all that are like really important in the general pathology. Then comes the hematology part. Sometimes questions can be asked from the hematology part also. Okay, so these are some of the really important topics from general pathology. Okay, so today let's first have a look at the questions that were asked in the recent NEET MDS 2024 exam, and then we will move on to some of the very important questions from general pathology. Okay, it is not much that of a tough subject. It is like easily retainable subject. So keep revising. Okay, then only you will remember the contents of this general pathology. Okay, keep revising again and again. So the first question is the type of chromosomal anomaly that is shown in this given image is. Okay, what is shown in this image here? What kind of like translocation is shown here? Is it or inversion is shown here? Okay, is it like Robertsonian translocation or paracentric or pericentric inversion or reciprocal translocation? Okay, so you can see from the image that some kind of like intermixing between the chromosomes has taken place. Okay, so what is this called? Okay, this is an image-based question that was asked in the recent NEET MDS 2024 examination. So, yes, doctors, if you have answers, you can post. Okay. Okay. So actually the answer is option D, reciprocal translocation. So let's see about the chromosomal abnormalities and what kind of translocation or inversion that is happening. Okay. So if you look at the cell inside the nucleus of the cell, you will be able to see something called as some structures called as chromosomes like this. Okay, so these are the chromosomes that are present inside the nucleus. Okay, so what are these chromosomes? Chromosomes are like specialized structures that are present inside the nucleus, which carry the DNA material or the genetic material. So if you look at the structure of this chromosome, it will have some fingers like this. Okay, so these fingers may not be like equal. One will be like two will be one or two will be like very long and one or two will be like very short also. Okay, so these finger like things that are seen in the chromosomes, they are called as chromatids. Okay, so they are called as chromatids. Now these chromatids are joined together at the center by a structure that is called as the centromere. Okay, so this structure is called as the centromere. The centromere position will not be the same for every chromosome. Sometimes it will be at the exact center. Sometimes it will be a little bit away from the center towards the terminal end. It can be seen like that. It can be seen. Okay, so if it is not present in the exact center, if it is present in somewhat towards the subterminal ends, then it can result in one chromatid with a very long arm and one with a short arm. Okay, so this short arm of that chromosome, it is called as the P arm, or it is also called as petite arm. Okay, so this is the P arm. The short arm is always called as the P arm or the petite arm, and the long one is called as the Q arm. Okay, next to P, the alphabet is Q, so they just mention it as Q arm. Okay, and at the end of these chromosomes, you will be able to see a structure. That is, at the terminal ends of this chromosome, you will be able to see a structure which is called as the telomere. Okay, so this telomere depends on determines the age of the cell. Okay, so for a new cell, the telomere length will be like really long. Okay, but after every cell division, this telomere length will again decrease and decrease and decrease. And once it is like an old cell or a senile cell, you will be able to see like like a very few portion of the telomere alone. Okay, so this telomere is an important component of this chromosome, which determines the age of the cell. Okay, so how do we know whether uh, whether the cell is like senile or new? By checking this telomere length alone. Okay, so the telomere length will be like very much decreased in case of a senile cell. Okay, so during the cell division, there will be like so many abnormalities happening in the chromosomes. So such chromosomal abnormalities can be classified into two types. We have the numerical abnormalities and the structural abnormalities. Okay, numerical abnormalities means there is some problem with the chromosome number. Okay, so we know the humans have like two types of cells. One is the uh, autosomes and the somatic cells and the uh, uh, gametocytes. Okay, so the gamete cells. Okay, so the somatic cells, gametocytes means it's the ovum in the females and the sperms in the males. Okay, so all the other cells other than these gamete cells, they are called as the somatic cells. Okay, so if you look at the somatic cells, all the somatic cells will have uh, a fixed number of chromosomes. That is 23 pairs of chromosomes will be there for every human cell. Okay, so these are 23 pairs of chromosomes or 46 chromosomes will be there for every cell. Okay, so if there is some change that is happening to this number of chromosome, then that is included under this numerical abnormalities. So the main examples of these numerical abnormalities include polyploidy and aneuploidy. Polyploidy means the in polyploidy you will be able to see that the cells will always be a multiple of the haploid form. Okay, so in humans, if it is 23, we generally take it as like 23 pairs. So it will always be like 3 multiplied by 23 or 4 multiplied by 23, like that only the variations can be seen. Okay, aneuploidy means it will not be a product of the multiple, like 2n minus 1 or 2n plus 1, all those differences can be seen. Okay, so the main examples of these are like the Down syndrome, Klinefelter syndrome, Turner syndrome are all examples of the numerical abnormalities that is happening in the chromosome. Then we have the structural abnormalities. So these structural abnormalities means while during the cell division, something is happening in the structure of the chromosomes. The number remains the same, but something is happening in the structure of the chromosomes that are called as structural abnormalities. And these structural abnormalities can again be classified into two. They can either be balanced or unbalanced in nature. So let's have a look at the structural abnormalities that is happening in the chromosomes. Okay, so the main examples of these structural abnormalities are translocations. That is, within the two chromosomes during the cell division, one part of the chromosome is getting cut and it is getting translocated to another part. Okay, like this, translocations can happen. Then we have the isochromosomes. Isochromosomes means usually during the cell division, this centromere, they gets divided vertically. But instead of the vertical division, if the centromere gets divided horizontally, then it will result in two short arms and two long arms like this. Okay, so those are called as the isochromosomes. Then we have something called as the inversions. Inversions means a part of the chromosome is getting cut and it is getting inverted in nature. You can see here the blue and the red part here, it is getting inverted and it is like completely getting ulta and getting fused here. Okay, so that is called as the inversions of the chromosome. Then deletions are happening. So deletions means a part of the chromosome is cut out and that fragment is lost. Okay, so that genetic material is lost completely. So that are called as deletions. Then we have the ring chromosomes. In ring chromosomes, what is happening is that the terminal ends, okay, these ring chromosomes can be considered as a part of the deletion process. Okay, so the terminal ends of the chromosomes are getting cut out and it will that portion will get fused with each other and it will form a ring structure like this. So all these are structural abnormalities of the chromosomes. And one important thing is this translocation. Okay, so there are two types of translocation. One is balanced reciprocal translocation and another one is centric fusion or the Robertsonian translocation. So let's see what this reciprocal and Robertsonian translocation is. So these are the two chromosomes, and during the cell division, if this portion is getting cut and is migrated towards here and it is relocated here, translocated here and getting fused with the other chromosome, then it will create a change like this. Okay, so in this change, if you look at it, there is no loss of genetic material is happening. That is, no fragment of the chromosome is getting lost in this process. Okay, so this kind of translocation, it is called as the reciprocal translocation. But there is another type of translocation too, that is called as the Robertsonian translocation. You look at the picture here. Here it shows the Robertsonian translocation. That is, mainly this kind of translocation happens to acrocentric chromosomes. So what do you mean by acrocentric chromosomes means like based upon the position of the centromere, you can divide the chromosomes into metacentric. If it is at the right center, if it is at the exact center, then the centromere is at the exact center, then it will create metacentric chromosomes. Equal length of the four chromatids can be seen. Then there is something called as a submetacentric. That is, it will be somewhat towards the terminal end. So it will result in two short arms and two long arms like this. Then we have the acrocentric chromosomes like this. Acrocentric means the centromere will be at the extreme, eccentrically placed at the extreme peripheral end. Okay, so that will result in a very rudimentary two arms and like really long arms also. Okay, so this is called as the acrocentric chromosomes, and these Robertsonian translocations usually happen in these acrocentric chromosomes only. Sorry. So it will result in the breakage and joining of these two long arms, and these two short arms, you know what happens? They eventually get lost. Okay, so that genetic material is getting lost. Okay, so that can create problems that can create the clinical symptoms also. Okay, so in the reciprocal translocation, no genetic material or no fragment is getting lost, whereas in the Robertsonian translocation, a fragment of the genetic material is getting lost. Okay, so that's the main difference between the two. Now, in the picture, it is mainly shown like just the translocation alone is shown. No, loss of genetic material is shown here. So we are mainly choosing the reciprocal type of translocation. Now, in the option B and C, they had mentioned about inversions. Okay, mainly the paracentric and the pericentric inversion. So let's have a look at what this inversion is. So this is the one arm of the chromosome. So what is happening during the cell division is that this particular portion is getting cut out and it is getting inverted as a whole. Okay, so you can see that here the red end is at the top end and the green end is at the bottom end. But during the paracentric inversion, inversion means it is getting inverted. Okay. Now, depending upon the position of the inversion, this inversion can be of two types. We have paracentric inversion and pericentric inversion. Paracentric means the centromere is not involved, only the terminal or the subterminal part is getting inverted. Whereas in pericentric inversion, what is happening is that the centromere is also getting involved. Okay, so that is called as a pericentric inversion. So this is the main difference between the paracentric and the pericentric inversion. So remember the numerical abnormalities, structural abnormalities are there. Transversion, like translocation is an important thing. Then you have the inversion, deletion, ring chromosome, and all the others are also included under the structural abnormalities. Have a look at the Robertsonian translocation and the reciprocal translocation also. Now, next is also a genetic related question. A child patient showed clinical features of mental retardation, flat facial profile, oblique palpebral fissures, epicanthic folds, and simian crease. What is the diagnosis? Is it trisomy 18, 13, 19, or 21? Okay, in most of the question, there will be something like a key point that you will be able to identify that will like directly take you to the answer. Okay, so the key point here is this simian crease. Okay, so what do you mean by simian crease and where will you see this simian crease? Simian crease is like a characteristic finding in Down syndrome. Okay, so Down syndrome is trisomy 21. That is, in the 21st chromosome, instead of just a pair of two chromosomes, we are seeing an extra genetic material which will result in Down syndrome. Okay, so let's have a look at the Down syndrome. So, like I already told, Down syndrome, the another name is trisomy 21. In trisomy 21, what is happening is that for the 21st chromosome, okay, so this is the karyotyping of the Down syndrome patient. As you can see, like in a human, like 23 chromosomes will be there. 22 pairs will be like autosomes, and then XY or XX can be there. In the 21st chromosome, you will be able to see an extra pair of chromosome here. Okay. So this is the trisomy 21. Okay, so what are the clinical features that you can see in a Down syndrome patient is definitely like mental retardation, like epicanthic folds and flat facial profile will be seen. Brachycephalic skull can be seen. Abundant neck skin. Simian crease. Okay, so what do you mean by simian crease is that usually in a normal individual, you will be able to see like two transverse crease across the hand, right? This is one transverse crease and this is another transverse crease. Okay. But in the Down syndrome patient, usually what we will be able to see is that only a single transverse crease is seen. Okay, such two lines will not be seen. Only a single transverse crease will be seen. Okay, so that crease is called as the simian crease. Simian means like monkey or ape. Okay, but nowadays this simian crease, the term is like not used. We just use the term like single transverse crease in the hands. Okay, only that term is used. We like discontinue the use of the simian crease. Okay, then definitely like heart defects, intestinal stenosis, umbilical hernia, and hypotonia. And in the legs also, you'll be able to see a large gap between the first and second toe is commonly seen for this Down syndrome patient. Now, the causes for this or the causes for this Down syndrome, it mainly includes like advanced maternal age, or because of some uterine and placental abnormalities, or because of some chromosomal aberrations happened that during the fertilization process. All these can lead to Down syndrome. It is one of the common syndromes that is seen, common genetic syndrome that is commonly seen in the child patients. Okay, so there are some specific oral manifestations for this Down syndrome patient also, like the drooping mouth, fissured tongue, enlarged circumvallate papillate, dry and fissured lips, and hypodontia, microdontia, the higher rate of periodontitis and lower rate of caries. Okay, that is all common features of this Down syndrome. Okay, have a look at these general features and oral manifestations. Now, next is multiple draining sinuses with matted lymph nodes are seen in. Is it seen in tuberculosis or actinomycosis or mumps or sarcoidosis? So, in the options given, the first three are infectious diseases, and the last one is a granulomatous disease only. Okay, so since it is an infectious disease and since it is a granulomatous disease, you will be able to see enlargement of the lymph node in all these diseases. Now, usually, when you palpate an enlarged lymph node in the submental region or in the submandibular region, you will be able to like palpate a single lymph node usually. Okay, but in one of the diseases, these what happens is that these lymph nodes, they can get clumped together. Okay, they can get clumped together and will give a matted appearance like that. So which disease is it is seen is mainly tuberculosis. Okay, so when the word draining sinuses is there in the question, you can get confused with actinomycosis also, because in actinomycosis also you'll be able to see like draining sinus with sulfur granule presence in it will be there. But matted lymph nodes are a characteristic feature of tuberculosis only. Okay, so this tuberculosis is nothing but it is a communicable chronic granulomatous disease which is caused due to the bacteria, Mycobacterium tuberculosis. Now, because there are like so many subspecies in the Mycobacterium, there is like a Mycobacterium tuberculosis, Mycobacterium bovis, then there is atypical Mycobacteria is also there. Okay, so what it does is that usually it will cause pulmonary infection. Okay, this Mycobacteria, they will directly go to the lungs and will produce the pulmonary infection. But sometimes it goes for the extrapulmonary cause also. That is, other than the lungs, it can also affect the lymph nodes. Mainly the posterior cervical and the supraclavicular lymph nodes can get affected. Okay, so this is called as the tuberculous lymphadenitis. It will result in something called as the tuberculous lymphadenitis. This tuberculous lymphadenitis is also called as scrofula. Okay, it is also called as scrofula, and it is also called as king's evil. Okay, king's evil is like a it's like a misterm that is used because in the ancient times, because the patients who suffered from such scrofula, they believe that the patients who had suffered from this scrofula, if a king touches that, it will heal. Okay, so that was not used nowadays. So it is nowadays it is called as a tuberculous cervical lymphadenitis, or it is also called as the scrofula. So what happens is that when these microorganisms, when they go and infect these posterior cervical lymph nodes or the supraclavicular nodes, what it initially a painless swelling of the lymph node can be there. Then it will the lymph nodes, it gets matted or it gets clumped together, and then a fistula as it progresses. Okay, as it progresses, sinus tract can also be seen draining the caseous material from those matted lymph nodes. Okay, so this is the characteristic feature of scrofula. Now, next, moving on to the next question. The Koplik spots are seen in, is it a bacterial infection or fungal infection or malignancy or viral infection? This is comparatively easy question because they had not specifically asked for the virus or the bacteria or like the organism, the microorganism that is causing these Koplik spots. Okay, just in a generalized way, they had asked like whether it is a bacterial, viral, or fungal infection, or whether it is seen in malignancy. Okay, comparatively easy question. Okay, so the Koplik spots are usually seen in a viral infection only. So let's see where we will see this Koplik infection or Koplik spots. These Koplik spots are usually seen in measles or rubiola, which is caused by the morbilli virus. Okay, which belongs to the Paramyxoviridae family. Okay, usually affects the children of 1 to 5 years. And if you look at the clinical course of this measles, it undergoes like 3 stages. Okay, so there'll be 3 stages of this measles, and each stage will be there for 3 days. Okay, so 3 stages, 3 days. Okay, so that's why it's called as 9-day measles. Okay, so it is, this measles is also called as this 9-day measles or rubiola. Okay, so this 9-day measles, let's have a look at what those 3 stages are. In the first stage, you will be able to see 3 C's. Okay, so the 3 C's means one is cough, then next one is coryza. Coryza means like inflammation of the nose and things. So cough, coryza, and conjunctivitis. These are the initial symptoms. Okay, that is seen in the initial stage of this measles. Okay, so cough, coryza, and conjunctivitis will be seen. Along with that, fever will also be seen. And one important oral manifestation during this first stage is this Koplik spots. You will be able to see like bluish white macular spots in the buccal mucosa, which will be like given appearance of a grains of salt appearance will be seen. Okay, so this is the grain of salt appearance of the Koplik spots. Okay, then next, the second stage, again the fever will persist, and along with the fever, you will be able to see the rash. Okay, so this rash, it will be like maculopapular or erythematous rash, mostly like called as the morbilliform rash, which can extend from head to toe. Okay, can affect all the regions of the body. Okay, so that is about the second stage. We'll be able to see the rash. Then moving on to the third stage, what happens is that the fever ends, the rash also starts fading, but there'll be like brown pigmentation and desquamation of the skin, like where the rashes had been there previously. You'll be able to see the desquamation of the skin also will be seen in the third stage. Okay, so in the first stage, remember the 3 C's, along with that Koplik spots also. In the second stage, fever and the rash. Third stage, all the symptoms will start fading and the desquamation of the skin will also start happening. Okay, so this is the characteristic feature in the measles. The next question. A patient admitted in the hospital with fracture in his leg bone. In the fracture of long bones, which type of emboli is most common? Okay, is it fat embolism or air embolism or blood embolism or decompression sickness? Okay, so before we start discussing about the embolism or the emboli, you should have an idea about what a thrombus is and what is thrombosis. Okay, thrombosis means like any interruption or any obstruction in the like the system, in the circulatory system, which is caused by the components of the blood. Okay, so that is called as the that process is called as thrombosis, and the material that causes this thrombosis, it is called as the thrombus. Okay, so in the initial stages, this thrombus will not be like very hard and will not be like at a particular place. Okay, so during the circulation, what happens is that this thrombus can get dislodged from its initial center, and it will translocate, or it will get migrated in the circulatory system and get embedded in, or and can cause the obstruction in another place. Okay, so this migrated thrombi, or this translocated thrombi, and which is causing a like a obstruction in another place, that is called as the emboli. Okay, and this process is called as the embolism. Okay, so this emboli can be based upon its composition. It can be either solid, liquid, or gaseous emboli are there. Then based upon its origin, like arterial or venous or like cardiac emboli are there. Then clinically, these types of embolism is like really important. One, you have the pulmonary embolism and the systemic embolism, fat embolism, air embolism, amniotic fluid embolism, and tumor embolism are all clinically important ones. And the common origin is also given here. Now, out of these, the one important one is the fat embolism. Okay, so this fat embolism, the main cause for this fat embolism is because of trauma to the bones or the soft tissues. Okay, so we will see like how this trauma to the bones or soft tissues is causing this fat embolism that can really be fatal for the patient also. Okay, so let's have a look at it. So the causes of the fat embolism can be traumatic or non-traumatic. Okay, the trauma cause is the most common one. Any trauma to the bones or soft tissues, any fracture of the bones or soft tissues can result in fat embolism. And the non-traumatic causes, it includes like burns, diabetes mellitus, fatty liver because of pancreatitis or sickle cell anemia, or because of the extrinsic fats also, it can result in fat embolism. Now, what happens is that when there is a trauma, or when there is a fracture that is happening to the bones and soft tissue, the fat globules will get released from that injured area. Okay, so the fat globules will get released from that injured area, and it will go to the venous circulation. Now, when it goes to the venous circulation, these fat globules, they will go and like get arrested in the small vessels in the lungs. Okay, since lungs have like a very wide vascular system, this fat globules, it will go and get arrested in the small vessels in the lungs. Okay, so that can create pulmonary fat embolism. Okay, so there are two types of fat embolism also. When it gets when these fat molecules go and get arrested in the lungs, that is the common site, it will create in the pulmonary fat embolism. And it can get lodged in other organs also, like the brain, kidney, skin, all are the organs where it can get lodged. So that will result in something called as systemic fat embolism also. Okay, so based upon the location where these fat globules are getting lodged, it can be like pulmonary fat embolism and systemic fat embolism also. Okay, if the fat globules are the ones that is getting lodged, it is called as the fat embolism. But in case of sometimes like the adipose tissue can also get also act as an emboli and can get lodged in the blood vessels, then that is called as the fat tissue embolism. Okay, so there is difference between fat embolism and fat tissue embolism. Fat embolism, just the fat globules will be there. Fat tissue means it is mainly the adipose tissue is involved. Okay, so you should know the idea between two. Now, this pulmonary fat embolism, if you it is a fatal cause. Okay, so the patients can die after the fracture of the bones. And usually, if you do autopsy for such patients, you will be able to see such pulmonary fat embolism in most of those patients. Okay, some kind of fat globule has traveled through the venous circulation and got dislodged in the small vessels in the lungs, causing this like the death of the patient. And systemic fat embolism, mainly brains, kidney, and skin are involved. Now, moving on to the next question. A child's CSF, the cerebrospinal fluid, was examined and it contained raised lymphocyte levels, absence of mycotic growth, protein levels are normal, and glucose level is also normal. What is the most probable diagnosis? Okay, so in the options, they are mainly given the types of meningitis, whether it is pyogenic bacterial meningitis or viral meningitis or fungal meningitis or tuberculous meningitis. Okay, so a child who is suffering from meningitis has come to the hospital and his or her like the CSF, the cerebrospinal fluid was taken and it was examined, and these are the findings. So what can be the which type of meningitis can it be? Okay, so let's look at the what meningitis is. Meningitis means it is an inflammatory process that is involving the leptomeninges, that is within the subarachnoid space. Okay, so this inflammation of the leptomeninges in the subarachnoid space, that is called as the meningitis. If this infection is spreading to the underlying brain also, then it is called as meningoencephalitis. Okay, so this meningitis, if you look at the classification, it can be caused due to infectious cause or it can be caused due to non-infectious cause. The infectious cause of the meningitis, it is divided into three types. One is the acute pyogenic or the bacterial cause. Okay, because of the bacterial infection, the meningitis is happening. Next one is the aseptic or the viral cause. And the third one is the chronic type or the because of the sorry, because of the tuberculosis or because of spirochetes, because of the fungal infections, the meningitis is happening. That belongs under the chronic type of meningitis. And non-infectious may be due to chemical causes or because of the carcinomatous causes, it can be there. Okay. So let's look at the CSF indices, the cerebrospinal fluid indices in each type of meningitis. Okay. So in the question, it was mentioned that lymphocytes were there. Okay. So in all the types except the bacterial type, bacterial one is the acute type. Okay. So the acute cells in an acute type of disease mostly will be seeing acute type of cells. The acute types of cells is the neutrophil. Okay, so the neutrophil will be most commonly seen in the bacterial type of meningitis. Whereas in all the other things, you will be able to see the lymphocytes also. And then it is also mentioned that the normal level of glucose and normal level of protein. Okay, when some kind of infection happens, usually in the CSF and all, usually the glucose levels can get decreased and the protein levels can get increased. Okay, but here it is specifically mentioned that the glucose levels and the protein levels are normal. Okay, so the which type of meningitis show normal glucose and protein levels? It is the viral type of meningitis on. Okay, so this viral type of meningitis shows normal levels of glucose and protein, and the predominant cell type is lymphocyte on. Okay, so the answer is viral meningitis for this question. So that's all the questions that were asked in the NEET MDS 2024 exam. Okay, comparatively easy. You just need to think about it. Some of very easy questions were there. Genetics, they were given importance in the last exam. So have a look at genetics also. In genetics also, comparatively, they had asked the easy type of question. Okay, sometimes if they really want to make the genetics part tough, then they could have asked about the pedigree based like questions also. Like they can give a pedigree chart and you have to read the pedigree chart and you have to like choose which type of inheritance pattern is that, and then you have to choose the disease associated with it also. Okay, so that is a little bit time consuming and a little bit confusing. It can be a little bit tricky if they gave the pedigree based image based questions. Okay, but luckily there were no pedigree based image based questions in the last NEET MDS 2024 examination. The image based question was also like comparatively easy only. So now let's have a look at some of the important high yield questions from the general pathology. Excuse me. A bedridden paralyzed patient was declared dead. On autopsy, which of the following type of necrosis is seen in the brain? Necrosis and apoptosis is an important topic in the pathology. So, can it be like liquefactive necrosis or coagulative necrosis or caseous necrosis or fat necrosis? Necrosis in the brain, it is usually liquefactive necrosis. So, let's have a look at what this necrosis is. Necrosis means it is the localized area of the death of the tissue. Okay, so in a particular area, the tissues are getting dead and it will be followed by the degradation of the tissue. Now, this dead tissue will release some enzymes that are called as the hydrolytic enzymes. Now, these hydrolytic enzymes, what it will does is that it will degrade the tissue and will clear off that area. Okay, so that is called as necrosis. Now, based upon the like various types of necrosis can be seen clinically. We'll be able to see coagulative necrosis, which is the most common type. Then liquefaction necrosis is also there. Caseous necrosis, fat necrosis, and fibrinoid necrosis are usually seen. Excuse me. So, in the coagulative necrosis is usually seen in the heart, spleen, and kidney. And liquefactive necrosis is most commonly seen in the brain and abscess cavity only. Okay. Fat necrosis in the pancreas and breast, and fibrinoid necrosis in the arterioles in hypertension and in peptic ulcer. And caseous necrosis is most commonly seen in the tuberculosis infection in the center of the foci. Okay. So, since in the question it is given like it is like a bedridden patient and like paralyzed patient was given, we can see that the type of necrosis that will be seen in the brain is usually liquefactive necrosis only. Okay, so in case of any bacterial or fungal infection in the brain, what happens is that there will be a rapid accumulation of the inflammatory cells in the brain. Okay, so this will result in lots of enzyme release from the inflammatory cells. Now, the enzymes released, what it does is that it will go and liquefy the tissue. Okay, it will go and liquefy the tissue and the tissue will get transformed to a viscous liquid. Okay, so this is what the main pathogenesis that is happening behind the liquefactive necrosis. In case of infection, lots of inflammatory cells. Okay, you can see the microscopic picture here and the gross picture here. You can see like lots of inflammatory cells are getting surrounded by that area. Okay, to kill those microorganisms. Okay, and these microorganisms will release like lots of enzymes also. Now these enzymes that are released, that will convert this brain tissue into something like a viscous liquid. Okay, and finally it gets cleared off by phagocytes. Okay, so this is the gross picture of the liquefactive necrosis of the brain. You can see this localized area here. Yes, that shows the liquefactive necrosis, and this is the biopsy picture of that same area. Okay, you can see that the area of necrosis is like largely surrounded by like lots of inflammatory cells and blood vessels, and glial cells are also seen. Since the brain, the glial cells are also seen here. So remember the like the locations of the necrosis. Usually in heart, spleen, and kidney, you'll be able to see coagulative necrosis, whereas in brain, it is usually liquefactive necrosis only. Now, next question. Which of the following is not a mediator of inflammation? Okay, so a similar question like this was asked in the recent INICT MDS November 24 exam also. So, which of the following is not a mediator of inflammation? So, inflammation means it is the protective response by the body to variety of the etiological agents. Okay, so these etiological agents can be infectious or non-infectious agents also. So, how the body reacts to these etiological agents, that is called as this inflammation. Okay, so the protective response by the body to these infectious or non-infectious agents, that is called as this inflammation. Now, this inflammation involves like lots of processes, like there will be vascular changes happening, there will be cellular changes happening, there will be like a transient vasoconstriction, then vasodilatation happening, then like the WBCs are getting like transported, immigrated, and then phagocytosis happening, like lots of processes are happening in the inflammation. Now these processes are all mediated by certain chemicals. Okay, so such chemicals are called as the chemical mediators of inflammation. Now these chemicals can be originated from cells, or they can get originated from the plasma also. Okay, so if these like mediators of inflammation are like originated from cells, then they are called as the cell derived mediators, and if it's from the plasma, they are called as the plasma derived mediators. So let's have a look at some of the cell derived mediators: the vasoactive amines, arachidonic acid metabolites, lysosomal components, cytokines, and free radicals. Okay, among these, the cytokines is very, very important. Like lots of research are happening around the cytokines only. So let's have a look at what these cytokines are. The cytokines are like polypeptide substances that are released during this and which act as an like a mediator of inflammation. They are mainly released from lymphocytes, okay, T lymphocytes and the macrophages or the monocytes. Okay, they are the main components which release the cytokines. The cytokines, they what their action is that sometimes they can act on their own cells and can cause some kind of like inflammatory response. Okay, so that is the main action of these cytokines. There are many cytokines involved in the inflammatory process, but some of the most common are tabulated here. Okay, one is the TNF or the tumor necrosis factor. Both alpha and beta are involved. It is released from the macrophages, mast cells, and the T lymphocytes. It mainly helps in the endothelial adhesion and the secretion of the cytokines, and systemic effects also it can produce. Then we have the interleukins. Okay, interleukin 1, interleukin 6, interleukin 7, 12, and 17. All are all are like principally involved in the inflammation. These are also released from the macrophages and the T lymphocytes, and the 12 is from the dendritic cells also, 17 is from the again from the T lymphocytes. It has like all the inflammatory processes like the fever, and it helps in the release of other cytokines also, like the interferon gamma, and the recruitment of neutrophils and monocytes are all done by these interleukins. Then we have the chemokines and the interferon gamma also. Okay, so out of the options given, interleukin 1, the tumor necrosis factor, and the interleukin 7 are all involved in the inflammatory process. Okay, they are all mediators of the inflammatory process. But the option C, which is the TGF beta, only tumor growth factor beta. Okay, that is not a like a mediator of inflammation. It is actually an anti-inflammatory cytokine. Okay, so what do you mean by anti-inflammatory cytokine? Means it like suppresses the action of the inflammatory cytokines. Okay, it is actually used to suppress the action of the inflammatory cytokines. Now there are mainly three components that are involved in the act as the anti-inflammatory cytokines. One is the IL-10, IL-4, and the TGF beta. Okay, so this TGF beta, IL-10, and IL-4 are anti-inflammatory cytokines. They actually suppress it. Okay, they do not promote it, they actually suppress it. Okay, so this TGF beta is also released by T cells and macrophages. They helps in reducing the inflammation, and mostly they have also other functions like they help in the embryonic development, wound healing, and tissue homeostasis are all helped by this TGF beta only. Okay, so TGF beta is a molecule that acts as an anti-inflammatory cytokine. Okay, so that is the odd one out. It is not a mediator of inflammation. Next question. A simple bacterial test for mutagenic carcinogens is, okay, so is it Ames test or redox test or bacteriophage or gene splicing? Okay, so to in the laboratories and in the like the industrial uses and all, we use like lots of chemicals. Okay, so some of these chemicals can act as carcinogens. Carcinogens means they have the ability to produce cancer in the humans. Okay, so how do we detect such chemical carcinogens? Okay, so there is a very simple test that we use for identifying such chemical carcinogens. Now, that test is called as the Ames test. Okay, so what we do in this Ames test is we'll take a Salmonella strain. Okay, Salmonella typhimurium strain. Okay, so in the Salmonella typhimurium strain, we take the strain which is histidine negative. Histidine negative means the organisms that are present in the strain will not have the capability to produce histidine. Okay, it does not have the capability to produce histidine. Okay, and we add this Salmonella strain along with that rat liver extract, and we will add the carcinogen to be tested also. Okay, and then we will culture it under 37 degrees Celsius for like 48 to 72 hours. We will culture it, and then we will look for the results. Okay, in the results in the culture plate, if we are not seeing any histidine, any bacterial colonies, okay, this is the histidine free media. Okay, so if we are not seeing, or the number of colonies that are formed in this culture plate is less, then we can confirm that okay, the chemical that we added is not carcinogenic. Okay, but if we are seeing more amount of like colonies in the culture plate, then we can confirm that okay, the carcinogen that we had added has the capability to produce some kind of mutation. Okay, because we added a strain that does not have the capacity to produce histidine. Okay, but in the culture plate, if we are getting a colony that has the capacity to produce histidine, then we can confirm that some kind of mutation has happened after adding this like chemical carcinogen into the mixture. Okay, so some kind of mutation has happened. That's why now these bacterial colonies are able to produce histidine. Okay, so with this simple test, we can identify the chemical carcinogens. Okay, so the test name is Ames test. Okay, so it is mainly used for detecting the presence of chemical carcinogen. Okay, like histidine negative Salmonella strain is usually used. Now, next question, all roads are seen in which type of AML? Okay, all roads. So the WBC neoplasms. Okay, so if you look at the neoplasms of the WBC, they can be broadly divided into three types. We have the lymphoid neoplasm, where the lymphocytes are usually involved. Then we have the myeloneoplasm and the histiocytic neoplasms. These are the three divisions of the WBC neoplasm. In the myeloneoplasm, it is again divided into acute myeloneuplemia or the myeloproliferative neoplasms and the myelodysplastic syndrome. Okay, so if you look at this acute myeloid leukemia, the FAB has given a classification for this acute myeloid leukemia or the AML. So this FAB means French American and British classification. So this, according to this classification, this AML is divided into like 8 types. Okay, so from M0 till M7. Okay, M0 is the least one, and the M7 is the like most progressive one. Okay, so there are like 8 classification that is given by the FAB classification. So according to this classification, if you look at it in M1, M2 and M3 only, you will be able to see the all roads. Okay, so M1, M2 and M3, and in the options only M3 is given. 1, 2, 3 is not there, so the 3 is only there, so we are choosing M3. Okay, so M3 will have the presence of all roads. Now let's see what is all roads are. So this is a myeloblastic neoplasm. Okay, so you'll be able to see large cells like this. Myeloblast will be seen, and this is the main nucleus. And in the cytoplasm, at the periphery of the cytoplasm, you'll be able to see like red or pink stained rod-like structures like this. Okay, red or pink stained rod-like structures like this. Yes, this is the all roads. Okay, so this is usually present in the neoplastic myeloblast, and it is usually considered as a hallmark feature of AML. Okay, so these all roads are considered like a hallmark feature of AML. Okay, and it is made of azurophilic granules. So this pictorial representation, you will be able to see more clearly. You'll be able to see like rod, like pink or reddish color structures here. Yes, they are the ore rods. Characteristic feature of AML, and in which type of AML? M1, M2, M3. Okay, in all the three types, you will be able to see. The next question. In a 32-year-old female patient, left supraclavicular lymph node biopsy histologically shows acidophilic owl eye nucleoli lying freely in empty spaces, showing immunohistocompatibility with CD15 and CD13. Okay, so it is suggestive of which type of lymphoma. Okay, so now in the last question, we had already had a look at the leukemia. In the list, this question, we are having to have a look at this lymphoma. Okay, is it nodular sclerosis or the lymphocytic predominant or the reactive nodular hypoplasia or the large cell lymphoma? Okay, in which type of lymphoma you will be able to see this key words like the acidophilic owl eye nucleoli. Okay, owl eye nucleoli suggest the Reed Sternberg cells. Okay, so this Reed Sternberg cells are a characteristic feature of Hodgkin's lymphoma. Now we need to look at like which type of Hodgkin's lymphoma will show this Reed Sternberg cells with empty space around it, and histopatho and immunohistochemically. Okay, immunohistocompatibility is like a what to say an advanced technique that we can do after the biopsy procedure. Okay, so that we'll be able to identify like special types of cells or special origin of the tissue or the cancer. We'll be able to do something like an advanced technique which is called as the immunohistocompatibility. Okay, so in the immunohistocompatibility, it is positive with CD15 and CD30. Okay, so let's have a look at it. So Hodgkin's lymphoma can be divided into two types, Hodgkin's and the non-Hodgkin's. Hodgkin's is characterized by the presence of Reed Sternberg cells. Okay, that characteristically have the owl eye appearance. You'll be able to see a large cell like this with a bilobed nucleus, and it will be like a mirror image of each other. Okay, and a prominent eosinophilic nucleus with a clear halo will be seen. Okay, so this is the owl eye appearance of the Reed Sternberg cells. Now, this Hodgkin lymphoma can again be classified into two types. We have the nodular lymphocyte predominant and the classical type. In the classical type, it is again divided into four types. Lymphocyte predominant, where you will be seeing like lots of lymphocytes, and nodular sclerosis, like lots of fibrous sclerosis can be seen in between the tumor cells. Mixed cellularity, all types of cells can be seen. Lymphocyte depletion. Okay, very dangerous form of Hodgkin's lymphoma is this lymphocyte depletion type, like scarcity of lymphocyte is usually seen. Now, these Reed Sternberg cells, based upon its like presence in various diseases, whether it is the lymphocyte predominant type or lymphocyte depletion type or in the nodular sclerosis type, different types of Reed Sternberg cells can be seen. Okay, so this the owl eye appearance, that is the classical Reedberg Stern cells, and then we have the mononuclear type also, like only one nucleus will be seen. Okay, that is a Hodgkin cell. And then we have the popcorn types. Okay, which is the lymphohistiocytic variant, which is usually seen in the lymphocyte predominant type. Okay, then this is the pleomorphic type, which does not have a particular structure. Okay, then that pleomorphic type is usually seen in the lymphocyte depletion type. And then we have the lacunar cell. Okay, so in the question, it is specifically mentioned that this cell is lying in a pericellular space or a free space. Okay, so they are referring to this lacunar cell only. Okay, so this lacunar cell is usually seen in the nodular sclerosis type. Okay, then you can see mummified type of cell also, but this is all very rare. Okay, usually the classical owl eye Reed Sternberg cells are seen. Okay, so in the lacunar cell, so these Reed Sternberg cells, if you look at the immunohistocompatibility, they will be like positive for certain markers. Okay, two markers they will be positive. One is CD15 and another one is CD30. Okay, they'll be positive for these two markers, all the Reed-Sternberg cells. Okay, but in in this type, okay, in one type of in a one histological subtype of this Hodgkin's lymphoma, it will show negativity for this Reed-Sternberg cells, which is the lymphocyte predominance type. In the lymphocyte predominance type, it will be usually the CD15 and CD30 markers will be usually negative for the Reed-Sternberg cells. Okay, in only that type it will be negative. In all the other types it will be positive only. Okay, so in such cases where it is negative, you can again use another marker for identify, which is the CD20 plus. Okay, so the question, it was specifically given like outline nuclei and empty spaces will be seen. So that shows the lacunar cells which are seen in the nodular sclerosis type. And if you look at the immunohistocompatibility in the nodular sclerosis type also, it shows positivity for CD15 and CD30. So the right answer is the nodular sclerosis type of Hodgkin's lymphoma. Okay, just remember this lymphocyte predominance also because it shows negativity for CD15 and CD30. Okay. Along with that, nodular lymphocyte predominant also. Okay, in the nodular lymphocyte predominant also, it shows negativity for CD15 and CD30. Okay, all the other ones will be positive for CD15 and 30. You don't have to like study in detail about this immunohistocompatibility process and all. Just remember the markers that will be positive for Reed-Sternberg cells, 15 and 30. Okay, easy to remember. Like 15 by multiplied by 2, 30. Okay, 15 and 30 will be positive. So that's all for today's session. Like I hope you got an idea about the pattern of questions and type of questions that can be asked for the general from the general pathology for the NEET MDS examination. If you have any doubts regarding these topics, you can definitely comment below this video. We'll definitely clear all your doubts. Now, like like I had already mentioned, nearly 30 days remaining for your NEET MDS examination. So keep studying, keep revising, and keep practicing MCQs daily also. Okay. So that's all for today. Thank you. Thank you so much for attending the session. Goodbye.